Fantastic to see everyone. Last week, there was no morning report because I was at the American Academy of Neurology conference in Seattle, which was awesome. And I got to meet our CP Solvers team member, Valeria, there in person, which was fantastic. And it was a great meeting to see 10,000 neurologists in one place. That confirmed, vaccinated, and masked neurologists in one place. And the week before, I apologize because you were here. My power went out at 8:59 and I couldn't get it back up to use the internet. And Doug filled in, which I heard was phenomenal and have been meaning to watch and learn from. So here we are. Excited to see everyone. Does anyone have a case they were hoping to present today, a neurology case? And do we have two volunteers who would like to discuss the case, ideally one identifying as a woman and one identifying as a man? We have a case from Antonio. Fantastic. Look forward to your case. Neurology case, right? Not renal failure or something like that. Okay, just making sure. Reza is here just in case, but those infratentorial organs, they trip me up every time. And do we have two people who would like to discuss the case with Antonio and myself? Who would like to discuss the case today? Reza, is that you volunteering to discuss the case? Reza loves—
I don't discuss anything supratentorial.
Oh, so we complement each other well, my friend. Reza secretly loves neurology. Maybe not so secretly. Okay, so who would like to volunteer to discuss the case? Reza, maybe you can share some words of inspiration. I can never get people to discuss the cases here. How can I capture your enthusiasm?
Well, I am sure. Oh my gosh, look at that, Sammy. As soon as you said Reza, Sammy.
Just by invoking Reza, then, so great. Sammy, that's fantastic. And then Sammy and Reza. No, Reza is going to get on an airplane. That would be a lot of fun and somewhat humbling to I would just probably quote accidentally log off and let Reza run with it. How about this? Why don't you, Antonio and Sammy, introduce yourselves to the group? And I'm sure by the end of that, someone will be inspired to discuss with you, Sammy, ideally someone identifying as a woman, if possible.
Okay, so hi everyone. My name is Antonio. I'm an internal medicine resident from Portugal. I've been following CP Solvers, I think, since the beginning or close to it, and I'm a huge fan. I don't get to attend these VMRs very often, but I always follow them on the website. And I still have to discuss a neurology case. I'm gathering some courage for that, but I think I have a nice case to present today, and I hope you enjoy it.
Fantastic. Thanks so much for joining us. And Sammy, and hopefully by then, Reza is adding words of encouragement, and your words of encouragement introduction, the fourth member of our team will, I'm sure, emerge from the crowd.
Yeah, and hi, I'm Sammy. I'm a sixth-year medical student from the Medical University of Graz in Austria. I'm a CP Solver follower since more than 2 years now, and I also watch every neurology morning report. I also read your book, which I highly recommend to everyone here. And yeah, I have never discussed the neurology case on Neuro VMR, but I like neurology and I'm very hyped for this session.
Fantastic. Sammy, great to have you joining us from Austria. So we have Austria, Portugal, and the third country's participant is? Reza is running out promotions for my book in the chat. Thank you, my friend.
I can volunteer if there's no one else.
Is there anyone else? Otherwise, we're happy to have you, Shema. Fantastic. Go ahead and introduce yourself and we'll go ahead and get started. Fantastic. you want to just introduce yourself, Shema? I think most people know you, but just in case.
Hi, hello everyone. I'm Shema, and currently I'm a fifth-year medical student from Berlin. And yeah, let's see what comes.
Fantastic. This is an amazing team. I'm excited for the case and a very European morning of participants and presenters. So I'm guessing it is, what is it, about 6, 7 p.m., something like that there, nighttime. So great to be stretching across the hemispheres here. So let's move from those hemispheres to the cerebral hemispheres. Hit us with the chief concern / chief complaint, Antonio.
Okay, so this is a patient presenting to the emergency room with loss of consciousness.
Loss of consciousness. Great.
Yes.
So Shema, when you hear loss of consciousness, what starts coming to mind for you?
So basically, again, the MIST schema that we all know, thinking of a metabolic issue. Is there any infectious agent, structural lesion like a subdural hemorrhage, or toxins like benzos, opioids, and also consider what I learned from a former VMR, that aphasia and dysarthria can make it much more difficult if we have a person that is in an altered mental state because due to the lack of communication. But yeah.
Great thoughts. So yes, the differential is broad, as for many chief concerns in neurology, right? There are potential primary neurologic things, and there are, of course, potential medical things that could cause, whether it's headache, loss of consciousness, weakness, any of the symptoms we've discussed in these morning reports. So I think that's a great first framework to start asking ourselves. You categorize them by MIST, but saying it even more broadly, right? Is there something primary neurological going on here, or is there something systemic, toxic, that's affecting the nervous system, but not emerging from the nervous system? Sammy, what's coming to mind for you?
Same, I think about the MIST mnemonic. I think about the 4 S's: stroke, sugar, seizure, syncope, which can all present with loss of consciousness. So we'd quickly check for if there maybe hypoglycemia, check the pupils for some opioid overdose or something like that. Treat first, what I can reverse fast. Yeah, then we have different buckets with all these entities. For example, syncope, we can think of vasovagal, cardiogenic, or orthostatic. Then we have seizures, where I'm not really an expert. Then we have stroke, which can also present with loss of consciousness, but wouldn't be that typical. I would maybe check for more, would maybe want to see more focal deficit to think of stroke, maybe this arrhythmia. And last, sugar. Hypoglycemia can basically manifest with every neurologic symptom possible. Yeah, those would be my first thoughts.
Fantastic thoughts. Also, I hadn't heard of was it 4 S's or 5 S's? Many S's, which is great. So yeah, I think one thing I'm wondering about, which I guess we'll learn soon, but we've done this exercise of limiting ourselves to as few words as possible, is this a loss of consciousness with return to consciousness, and the patient is now there to tell us that this happened, or is this a loss of consciousness with persistent impaired consciousnesses that would take us down potentially different paths? If this is a loss of consciousness with return to consciousness, people usually say, well, that's probably either seizure or syncope. And then, as you both said, seizure can have many causes, syncope can have many causes. But I like these 5 S's because those aren't the only 2 things that could cause a transient neurologic event. You mentioned stroke, and you're right, ischemic stroke generally won't present with loss of consciousness because you're getting some area of focal brain ischemia, and you should have focal deficits. If someone had a basilar thrombosis or a transient ischemic event through the basilar, then the consciousness centers are there at the sort of upper brainstem, upper pons, lower midbrain. And if those are ischemic, then yes, loss of consciousness is possible, but a little less likely for ischemic stroke. But an intracerebral hemorrhage or a subarachnoid hemorrhage, by virtue of, in the case of intracerebral hemorrhage, mass effect, and by virtue of hydrocephalus, in the case of subarachnoid hemorrhage, then one could have alterations of consciousness from the beginning. Again, presumably not that the patient lost consciousness and then recovered, but lost consciousness and stayed with loss of consciousness. And then you mentioned sugar, and I'll use sugar as sort of just the broader, so intermittent hypoglycemia, there's, I forget how long ago it was, but maybe a relatively, no, I don't remember how recent it was, maybe Reza knows, a New England Journal CPC that looked very neurological, the events, and they were neurological technically, but the cause was intermittent hypoglycemia from an insulinoma. So that's a great thought. And then just thinking of sugar, you know, I'll go back to Seamus thinking of toxin, just thinking about things that could have come from the inside or the outside that are toxic metabolic, which is in our differential for every sort of neurologic condition. And I'll tell you a quick story, because, you know, I like stories of cases that stuck in my mind, but I was consulted once on the inpatient service for a patient who had acute coma. And they said this patient was very hypertensive, and we gave them diltiazem 10. Blood pressure didn't come down. We gave them diltiazem 10 again. Blood pressure didn't come down. Gave them diltiazem 10 again. The blood pressure stayed high, and the patient became obtunded. And I thought, oh, I'm hearing this over the phone. Very hypertensive, now obtunded. This patient probably had a huge hemorrhage. And I got to the bedside. The patient was obtunded. We're rushing to the CT scanner. And the CT is totally normal. And then the medicine resident with me gets a page and looks up and says, pharmacy error. The diltiazem was diazepam. So the patient was hypertensive and got diazepam, 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 right? And then I have another story of a patient, a resident colleague of mine saw, just so always toxic metabolic is in our differential for everything, that it was a flight attendant, and on the flight, on the way down, she took her vitamins and then started to feel a little bit off and started to sort of get sleepier and very ataxic. And my colleague who saw her in the emergency room thought she was having a big cerebellar stroke or hemorrhage, very ataxic, couldn't stay awake. Then again, went through the imaging, everything was normal. Patient got better, looked in her purse and said, oops, instead of my 3 vitamins, I took 3 Ambiens. And so toxic metabolic always in the differential here. And then the one other thing for sort of gourmet neurology, loss of consciousness, I've never seen this, but is reported. If a patient has a colloid cyst of the third ventricle, which is a benign lesion in terms of its histology, histopathology, these can have sort of a ball valve effect and kind of occlude the third ventricle and cause sort of sudden onset hydrocephalus. And these patients can have sort of events where after being in a certain position, they can acutely lose consciousness. So, so right, is this seizure versus syncope, or is the patient still obtunded? And then we would have to broaden. And if it is seizure or syncope, we'll have to think about in the history how to distinguish those. So let me, just to be able to ask one more question, let me ask you this, Antonio. Was this loss of consciousness with return to consciousness, or this is loss of consciousness and the patient is presenting still in an altered state?
Do you want me to characterize the episode better, or just to answer that question?
For now, if you don't mind, thank you for asking to just answer that question, because I'm going to ask Shema and Sammy.
The patient returns to consciousness.
Great, patient return to consciousness, perfect. So seizure versus syncope, as you both said, plus many other things. As you're hearing the history, so I think you were first, Shema, so Sammy, as you're hearing the history, what features would you be listening for and asking about to try to distinguish seizure from syncope?
I would first ask, was there post-ictal state, for example, sleepiness? How was the patient's mental status after the event? For example, when you have a syncope, your brain gets hypoperfused, then you kind of fall to the ground, your brain catches up with the perfusion, and you should return fast to your consciousness, for example, or in contrast to seizure, where this maybe takes a more time and people are sleepy after that. I would also check for a tongue bite, although people, when they fall, can also have tongue bites, but there is this pearl that when it's more on the lateral side, pushes you more towards a seizure. When it's more at the front of the tongue, more syncope, because you fall on your head because your brain gets hypoperfused. loss of urine isn't that specific for any of those, because you also can have incontinence in syncope, so I wouldn't rely that heavily on that. Yeah, this would be my first branch points, I guess.
Yeah, brilliant discussion, both in terms of the points you mentioned and in terms of the that they are not perfect, right? So we all learn in medical school, right? Well, the postictal state, if the patient has prolonged confusion, that's more suggestive of seizure. And whereas syncope, usually the patient wakes right back up. I should say, many of these events are not witnessed, right? Someone hears a thud, and by the time they find the patient, if they had a seizure, it's over, and if they had syncope, it's over. So if someone actually sees the event, that they're shaking, jerking, foaming at the mouth, eyes rolled back, that's a little more straightforward. But often it's we don't know. And I can say, as a neurologist who's called for seizures a lot of times, by the time I get to the bedside, it's over, and you're piecing together history, unless the patient was on EEG video monitoring, then we can watch a video. But even then, there are videos, actually, I think they're from Germany, of German medical students. One of my colleagues shows these, they're very old videos, where the patients are made to syncopize, I think by some brief occlusion of their carotids. And a lot of them have some twitching, jerking. And if you show these videos to rooms full of neurologists, people can't tell if it's seizure or syncope, even when you see it. And then just from the history, it's even trickier. But what if the patient has syncope and really hits their head hard on the way down and has a concussion? Then they might have a prolonged sort of loss of consciousness also. As you mentioned, the tongue bite classically is more suggestive of seizure, but if you fall while you were saying something with syncope, or your tongue is in a certain place, it might get bitten on the way down. Incontinence is supposed to be more with generalized seizure, but if someone gets up to go to the bathroom in the middle of the night and has micturition syncope, actually, no, that would be the wrong order of events, but has a full bladder and has orthostatic hypotension when they stand up and syncopizes, the bladder might empty. So none of these are perfect. We always ask about them, but might not get us to the answer. So I'm glad that you recognize both the sort of classic features, and that they're, as with most things in medicine, right, there's the version 101 where you sort of learn the facts, and then version 202 where you realize there's a million exceptions to all the quote facts, right? Great. Okay, Antonio. Yeah. Why don't you give us the history, and then have you discuss that, Sammy, and then we'll go from there.
Okay. So this is a middle-aged man that presented with 2 episodes of sudden loss of consciousness. He described that these episodes happened when he was standing up, and he gave us no prodromal symptoms. No chest pain, no palpitations, no sweating, no dyspnea. The loss of consciousness was self-limited, and he returned to an awake state within a few seconds, although it was hard for him to precise how many seconds. And then when he returned to consciousness, he described no confusion, no headache, no anything at all. But on arrival to the emergency department, when we started to examine him, and I won't give any physical exam, he just described that he was feeling some dizziness / vertigo and difficulty standing up and maintaining his posture while standing. And that's it. That's the first aliquot.
Great. Okay, Sammy, you got answers to some of your questions here and some other information as well. What are you thinking based on this history?
The first part with the loss of consciousness when standing up makes me think of orthostatic hypotension, which can have many causes, medications that influence blood pressure, autonomic dysfunction, which can happen in Parkinson's disease, in Parkinson plus syndromes, etc. Adrenal insufficiency, hypovolemic or hypervolemic state, for example, heart failure, liver cirrhosis, nephrotic syndrome, but also when you have a lot of volume loss and when you stand up, your brain gets hypoperfused, but also adrenal insufficiency, and very seldom scurvy is also a cause of orthostatic hypotension. The second part with the dizziness and the vertigo makes me more think of a vestibular cause or a cerebral or cerebellar cause, because he's having difficulty maintaining the posture while standing. Would maybe focus me a lot more on the neurologic system, and I would get a thorough neurologic exam and check for cerebellar signs, reflexes. Yes, this would be my first approach, I think.
Yeah, great thoughts, right? So we hear that the patient had an episode of sort of collapse while standing with loss of consciousness and seems to be awake right afterward. And we don't hear about any abnormal motor movements, which you'd expect in motor seizures, although seizures, depending on where they originate from and spread to in the brain, can really cause almost anything. But presumably, if this was seizure, right, it would have to be bilateral for there to be loss of consciousness. But there's not too much there pointing to seizure, as you said, and things pointing more towards syncope. And yet there was not sort of the prodromal features most people would usually identify, though they might not remember, that they sort of feel that rising warmth or, eyes going dark, graying out of vision. And then we get this other piece, right, which is a little bit challenging to integrate, right? That the patient has had these two events and is now dizzy or has vertigo, which if that becomes a key feature, we can talk a lot more about, and having difficulty sort of standing up. So you appropriately, I think, brought that back to the cerebellum to ask, is there something acute and cerebellar going on here that is causing the patient to have difficulty maintaining postural stability, and dizziness, vertigo could go along with that, probably something in the medial, the vermis of the cerebellum, but not immediately clear, right, as you said, how that would lead to a loss of consciousness, right? If there was a cerebellar infarct, is that happening now in these other two episodes? Then how are they related to it? And if there's a cerebellar lesion of some sort, infarct or otherwise, why did the patient lose consciousness? So either sort of, if you start with the loss of consciousness and try to get to the cerebellum, we get tripped up. And if we start with the cerebellum and try to get to loss of consciousness, we get tripped up. So a little hard to connect those dots. So I have a couple of other thoughts, but let's see where we are with time. Okay, I'll say my thoughts so we have time to discuss other aliquots too. And Reza will have to get on the plane soon, and he'll think, why'd they spend the whole morning report on the chief concern and not move much further? So I guess one possibility, what if those events of collapse, if we're trying to sort of stay with Sammy's hypothesis of the posterior fossa here, what if those two episodes of collapse were something I alluded to before? What if this patient has had two posterior circulation TIAs? What if there's, you would think, well, what if the patient has AFib? Why would the embolism keep going to the same place? But what if the patient has very advanced basilar artery stenosis and is having intermittent full or near full occlusion that has caused them to lose consciousness? And then one of these now has flicked off to one of the cerebellar arteries, SCA, AICA, or PICA, and actually given him a stroke this time. And fortunately for him, a small stroke and not a sort of full basilar occlusion type of stroke. I guess that's one way I could relate those things. Or is the dizziness, vertigo, postural, not cerebellar at all? And that's sort of leading us astray. And that's something we should be able to tease apart on the exam. So let's hear a little more information, Antonio, and see how that guides our discussion.
Is it okay if I give you the past medical history and the physical exam? Okay, so past medical history is relevant for 3 years prior liver transplant due to alcoholic liver cirrhosis and also liver cancer. So just a small nodule, but hepatocarcinoma, and he had liver transplant for that. And also he had some hypertension and obesity. Usual medications included tacrolimus and mycophenolate. And he kept his usual appointments with his gastroenterologist that was following him up post-transplant. and some anti-hypertensive medications that he could not name. Other than that, he was abstinent from alcohol since before his transplant, of course. No relevant family history. He was a non-smoker currently, and he had no known medical or drug allergies.
Let me pause you there, Antonio, before you tell us the exam, if that's okay. Shame, I'll ask you to discuss the exam. So curious what you're thinking at this point and how you would focus your exam. Obviously, we'll do a complete neuro exam, but what things in particular are you looking for? And or feel free to comment on what made us all raise our eyebrows, which is the history of liver transplantation and subsequent immunosuppression.
Well, the key question when it comes to this liver issue, the first thing that I was actually thinking, because tackling the difficulty standing up while standing, I was actually thinking of nutritional deficiency like vitamin B12 deficiency. So if we have any proprioceptive problem, and also thinking of this transplantation, is there any immunosuppression leading to opportunistic infections? Yeah,
great thoughts. Let me quickly comment on that. Right, we all heard liver transplant and knew that hearing about immunosuppression wasn't far behind. So then we have to ask ourselves whether there could be something infectious in the nervous system, and then the toxicities of these medications. I'm not aware of neurologic toxicity of mycophenolate. Tacrolimus, the most common. Does anyone know what the most common neurologic side effect of that medication is? It's tremor. So yeah, when I did my residency and my intern year, we spent a lot of time on bone marrow transplant service because there's a big bone marrow transplant service, and almost everyone was on tacrolimus, and almost all of them had tremor. It's usually a very coarse kind of action tremor, and it's common even when the drug levels are normal. It can also cause PRES, posterior reversible encephalopathy syndrome, and can cause, I think, a sort of more subacute chronic encephalopathy, even with normal levels, so someone would have to double check me on that. Of course, the liver transplant could be failing and the patient could be developing liver failure, and we would see hopefully evidence, well, not hopefully, but hopefully for our diagnostic process, evidence of that on the physical exam, if that's what's at play here. How that would be causing episodic loss of consciousness, I can't think of an obvious way, right? Hepatic encephalopathy, this is not the picture of that. So I think if we're thinking about infections or hepatic complications, we still have to back up, right, and ask ourselves, what is this syndrome? It's a syndrome of repeated loss of consciousness, and now there's a syndrome of postural instability. And we still don't, I think, have a good sense of where we are in the nervous system, right? And sometimes in these morning reports, as in real life, right, you get to the physical exam kind of already understanding that this sounds very Parkinsonian. This really sounds like a myelopathy, and the exam is confirmatory. But here, it's one of those cases where you get to the exam and really feel like the exam is going to actually really give us a lot of information that's going to help us understand what the syndrome is, right? Because we could list all kinds of infectious neurologic complications of immunosuppression, but would any of them be expected to cause loss of consciousness? That doesn't really sound like seizure and then postural instability, unless these are seizures, and the history, as often is not, as convincing, and there's some type of mixture of cortical lesions causing seizures and something in the posterior fossa, some disseminated infection. But I agree with you, Shema, taking the postural instability and pulling it aside for a moment and asking what would we look for. Is there a cerebellar pattern of ataxia here, as we would see finger, nose, and heel shin, or truncal instability and titubation, sort of shaking of that head when there's sort of midline cerebellar lesion? Or is the postural instability from proprioceptive difficulties, which could be from neuropathy, myelopathy, and as you said, those can be from vitamin deficiencies, although then unclear how those would cause loss of consciousness. Presumably, if this is a more kind of appendicular, in other words, well, that's probably not the right word. If this is a more proprioceptive problem, the patient in principle wouldn't be saying they had vertigo, though some patients use dizziness to describe a sense of instability. And one of my mentors, Marty Samuels, used to ask, or still asks, probably likes to ask, and taught us to ask the patient, are you dizzy in your head or dizzy in your feet? Because some patients mean dizzy that they're unsteady on their feet, rather than sort of the sensation of dizziness in one's head. So I have no idea what's going on here. Let's see what's going on the physical exam. Tell us what you found, Antonio.
Okay, so I'm really excited about this physical exam.
So are we.
Vital signs were normal, including Noah. I'm sorry for that. We could not get orthostatic vital signs due to the patient's unsteadiness. We checked for pulse differences between the right and left arm and blood pressure differences. There were none. And his physical exam, cardiopulmonary exam, abdomen were all normal, non-relevant exam. His neuro exam was relevant for multidirectional nystagmus that was non-suppressible. He had right eye ptosis and right eye meiosis. He had loss of temperature sensation in his left side of the body without the face, so just the arm and leg. And he actually noticed this, something that he mentioned during his admission, that when he bathed, he could not feel the temperature of the shower on his left side of the body. That's how he noticed it. And finally, he had some significant dysmetria on his right arm and right leg. That was the same with his eyes open and his eyes closed. And his Romberg test was negative due to severe unsteadiness. And we cannot see him walking because of it. He was severely unsteady when he standed. And that ends the physical exam.
Fantastic. Shema, there are so many findings here. What's going on?
So the first thing that came into my eyes is actually seeing that we have crossed symptoms, like one kind of symptoms are on the right side and other symptoms are on the left side, which makes me think of a crossed brainstem lesion. Like my first thought was something like Wallenberg syndrome, where we have let me check how I can translate it. It's kind of a stroke in the PICA, like the lateral medulla is affected, which can lead to kind of unconsciousness, but also like we don't have any motor insufficiency. It's actually only like dissociated sensibility impairment. And as far as I remember, we can also have something like an incomplete Horner syndrome. Am I right? And I think, and also these cerebellar signs. Yeah.
Fantastic. And thank you for telling us the appropriate pronunciation of what we call, hold your ears in America, Wallenberg syndrome. Wallenberg is probably the correct how the good doctor was called in his time. Fantastic. So when we first heard multi-directional nystagmus or direction-changing nystagmus, we knew we were talking about central nystagmus. That's a rabbit hole we won't have time to go on today. And then we heard about ptosis. So we might be thinking, is this a third nerve palsy? Is this a Horner's oculosympathetic lesion? Or is this myasthenia? Or is this some local eye process? And then the pupil is going to help you, right? Big pupil, big ptosis, or impressive ptosis lit all the way down, third nerve palsy. Small pupil, not much ptosis, Horner syndrome, right? And that can be anywhere from the hypothalamus down through the brainstem, down through the spinal cord, up over the lung apex, along the carotid, and through the cavernous sinus. We don't hear about weakness, right? And then we hear about this loss of temperature sensation on the left side of the body. And Shema, notice that, hey, we have symptoms on one side of the face, the other side of the body, that is a brainstem cross signs scenario, because the long tracks from and to the body, corticospinal on the way down, anterolateral and dorsal columns on the way up, right, are crossed, but the cranial nerve pathways to the face are uncrossed except for 4, though there's no clinical relevance to that in my to my knowledge. So we have cross signs, we have sensory plus cerebellar, right? And this is a lateral brainstem syndrome. So the lateral brainstem syndromes tend to affect more the cerebellum and the sensory pathways for the face and body. And the medial brainstem syndromes tend to affect the corticospinal tracts and the motor cranial nerves. So 3, 4, 6, 12 are the motor, pure motor cranial nerves. They exit right through the midline of the brainstem. And then 5 motor, 7, 9, and 10 are slightly more lateral. And then 8 and the sensory of 5 are the most lateral. So you have pure motor, bronchial motor, and then sensory, special sensory, most lateral. So these lateral brainstem syndromes, of which lateral medullary is the most common, or Wallenberg, or more appropriately Wallenberg, as Shema pronounced for us, are showing us mostly sensory signs plus cerebellar without much motor, though you can get 9 and 10, which are bronchial motor and slightly more lateral in this syndrome, and the patient would then have dysarthria, hypophonia, dysphagia, et cetera, but depends on the size of the lesion. And Shema localizes perfectly. This is in the right lateral medulla. That's why we get all the right-sided signs from the cerebellum, which is ipsilateral, in the face, which is ipsilateral, but left for the body, because remember the spinothalamic tracts crossed down in the spinal cord and are already on the opposite side. And she told us this is a syndrome of the posterior inferior cerebellar artery, or the pica. And Shema, do you know what artery the pica arises from? The parent artery of the pica?
Oh gosh, I always confuse it with the ICA. Let me check. I would have said the PICA comes from the vertebral artery.
That's
Please?
correct.
Yeah!
That's correct. Oh, I love your excitement about this. That's correct in most patients. Yeah, we also, I sort of learned in med school, probably incorrectly, or just imagine that they would all kind of come off the basilar. But yeah, the pica comes off the vertebral in most patients, and the AICA and the SCA come off the basilar, and they sort of line up with the levels of the brainstem: SCA midbrain, AICA pons, pica medulla, and then pica comes off the vertebral artery. Since it's kind of the first exit off the highway of the vertebral, it's a fairly common site of cardioembolism, but it's often can also be affected by vertebral artery disease, a vertebral artery dissection or vertebral occlusion. But the reason I asked about whether it comes off the basilar or not, well, was to make those teaching points, but also because of this question of what those episodes of loss of consciousness are. I think we have a good understanding of why the patient is vertiginous and unstable, but why were they losing consciousness? And if you had a basilar artery problem, the pica is not going to be affected, right? Because the pica comes off before the basilar. So I guess we could wonder, is there severe vertebral artery disease on one side that's been flicking stuff up into the basilar and then finally occluded and took out pica, but the rest of what was above that was able to be filled from the contralateral vertebral artery through the basilar. And then how does any of this relate to liver transplant, tacrolimus, mycophenolate? No immediate obvious connection for me. Any other thoughts, Sammy or Shema, on what to do with the fact that we've diagnosed lateral medullary syndrome in terms of figuring out what those losses of consciousness were, in terms of whether there is any relationship to the liver transplant immunosuppression? Any further thoughts on that before we decide what tests we want to order from Antonio?
Yeah, somehow we need to explain if there's the stroke, either it was hemorrhagic or ischemic. I was just thinking, I think the crawlymos can also induce thrombotic microangiopathy and cause strokes. So I would be curious about the CBC, if there's any thrombocytopenia. And we also need to get imaging, check the heart, the rhythm, and also the vertebral artery and the cerebral arteries. That's that was just an idea I had.
Yeah, great. Any further thoughts, Shema? Or a test you'd like to order?
What test I would like to order? Actually, an MRI of the head. Yeah.
Yeah. So this is a case where I think we know what we're going to see. And you mentioned, could it be hemorrhagic? Sam, you know, the medulla is so small, it's probably a little bit bigger than your thumb. If the patient had a hemorrhage in there, the idea that it would sort of stay localized to what really is a very vascular territory would be a little less likely. I think of it, you know, an ischemic territory is like a state or a country, right? And when there's a rainstorm, the rainstorm doesn't sort of stop at the border and say, "Oh no, I'm only raining in, you know, Germany and not going into Austria," right? And the hemorrhage, that's the metaphor for hemorrhage, right? The hemorrhage would just, you know, unless it's a very tiny hemorrhage, to kind of really kind of fill in those boundaries would be a little less like. Of course, we want to have imaging and make sure. We never really heard for sure that this was acute. Could there be a infectious lesion back there in the lateral medulla? You know, small structural lesion, I guess that's possible. My sense from the history is that this patient had 2 episodes, was normal, and then after this, and then now has these symptoms acutely. And lateral medullary syndrome just also makes us think about vascular causes, and all those brainstem syndromes, I should say most of them were described in the context of stroke. One of them, I forget if it's Weber, Benedict, or Claude, one of the 3 midbrain syndromes. I found the original paper and they described that the cause in the patient was a tuberculoma the size of a goose egg or something very colorful like that, naming the egg and the type of bird egg it was. So not all vascular, but could this patient have a tuberculoma or some other you know, abscess or something like that hiding in the lateral medulla here? Because we're not really sure how acute these symptoms are. I guess that's possible, and maybe allow us to have a more coherent story, unless this patient, the hypertension is the key part of the past medical history and not the liver transplant and immunosuppression. And this patient has atherosclerosis of the vertebrobasilar system and had a stroke and has been throwing some stuff higher up that's transiently occluded the basilar, causing him to have these sort of drop spells, if you will. So I agree, imaging is going to be helpful here. We think we're going to see a stroke, but just as I was saying that, I changed my mind that we could potentially see other things. It'll be good to get an MR angiogram with that MRI and see what's happening in the vertebral artery there. If this is indeed a stroke, if resources were limited, we could get the MRI first, make sure it's a stroke before the cost and resources of an MRA, but we could also do them together if resources permit. And other tests I would get would be based on those. I think if this is not a stroke, do we need to be looking at cerebrospinal fluid in the context of immunosuppression? And if it is a stroke, I think we'll be still scratching our heads on how the whole thing fits together. So tell us what you and your team ordered, Antonio, and what you found, and maybe if we have data that leads us up to but doesn't give the final diagnosis, we can maybe have a little more discussion before you reveal that to us.
Okay, yeah, I'll have one more aliquot, and then the next one will be the final one. The first test was blood glucose, which revealed normal blood glucose. An EKG was also normal, sinus rhythm, with no changes. His blood tests, basically blood counts, liver chemistries, kidney function, electrolytes, they were all normal. We ordered some tacrolimus levels that were normal as well in the therapeutic range, and some syphilis serology, which was negative. Of course, he did a CT of the head and neck with angiogram in the emergency department, which was normal and revealed no changes, including vertebral artery dissection. During admission, he also did an ultrasound of the cervical vessels that was also normal, no atherosclerosis, and it was negative for subclavian steal syndrome as well. And he had an echocardiogram that was also normal. And the next aliquot will reveal the diagnosis.
Great. Thanks for mentioning subclavian steel. That had crossed my mind at one point. It seems very popular on board exams, but I'm not sure I've ever seen a case in real life. Yeah, just thinking of the sense of loss of consciousness with some type of cerebrovascular disease, although I guess the stenosis would be, is it distal to the basilar, or it's proximal to the basilar in the subclavian, right? So that the arm is stealing from the basilar, causing the loss of consciousness. So then I guess you could get artery to artery embolism up through that subclavian stenosis or something like that. Anyway, I'm glad you mentioned that as something probably we should all keep in our minds, that we think a lot about when we're studying for the boards, but then probably never someone tell me if you've seen a case. I've never seen a case in real life. Okay, so the final test is going to reveal the final diagnosis, and I think we've all sort of said what we're expecting the last test to be was the one we all wanted, right? Was the MRI. And so I guess I'll ask, before that, we have a normal CTA. We have a normal CT, although the posterior fossa is not that well imaged on CT because there's a lot of bone hardening artifact and just the cuts are not that thick, and it's not a great place to see small pathology in a small space. I think the question is this a stroke or not? And if it's a stroke, where did it come from if the head and neck vessels are clear? So let's cast our votes on that. Sammy, Shema, and myself. Is this a stroke or not? And if not, what is it? And if so, where did it come from? And I'll preface this by saying I don't know the answer either. So we're all just making our educated guesses. And this is something you probably heard me say before, but I always say to my students and trainees is before you get imaging, really ask yourself what you think you're going to see and really try to visualize it in your mind, because and when you see it, if it's a match, I think there's some emotional valence there that has it seeps into your brain and memory of cases you saw. And if it's not a match, there's a big emotional valence of, like the Stroop test, right? This test where the words for color are written in a different color, like the word red is written in the color green, the word green is written in the color red, and you're supposed to say the color and not read the word, and your brain keeps bumping up against itself trying to do this. When that happens, and you say, I'm positive the MRI is going to show this, and it doesn't, again, there's, I think, a big sort of learning valence there, as opposed to just saying, let's see what's on the MRI, and then you see it, and then there's a little less emotional valence for learning. So cast your votes. Shema, stroke or no stroke?
I still wouldn't exclude it. We were reading through I would still do the MRI to say that this would be the guaranteed exclusion of a stroke, because like I don't know how it is for the PICA, but I guess if we have an MRI, we can surely exclude it. But at the moment, I'm very open for any solution.
Always good to be open for any solution, especially in neurology. Yeah, you asked, would an MRI definitively rule in or rule out stroke? So the diffusion-weighted imaging sequences that look at the diffusion of water molecules through tissue, and diffusion is restricted when there are many causes, but the most common use of this sequence is for stroke, because cytotoxic edema, the cells swell, it's harder for water molecules to diffuse. This is very sensitive within probably an hours of stroke, but it's not perfectly sensitive like any test, and can sometimes be negative, most commonly in the posterior fossa. I think the false negative rate is 6 or 7%. Don't quote me on that. There's a review from a few years ago. Ed Lowe is the first author, and the most common predictor of the MRI negative stroke, and you might say, well, how did they know? Well, they repeat the MRI and then they see it later, is posterior fossa, because the patient might move a little bit. It's a small region to be imaged. So, and then Sammy, stroke or no stroke?
Yeah, I would also go with stroke. And I was also thinking maybe a PFO, check for DVT risk factors and do some, go back in the history. Was it after Valsalva? But this is everything I could add, I think.
Yeah, I think you're right. I mean, that lateral medullary syndrome, again, that's a really small area, and the borders of it, right? Who decides what the borders of anything are? What decides them there are the vascular distribution. And to think that there would be an infectious abscess back there, or a post-transplant lymphoproliferative lesion that's sort of just went to the borders of the vascular territory and stopped. Just hard for me to imagine. And a patient with a brainstem infection, which we call rhombencephalitis, like a listeria rhombencephalitis, I just think this patient would be much sicker. So I'm going to agree with you that I think we're going to see a stroke. Those episodes of loss of consciousness are confusing to me because if we wanted to tie this all together, which we may not be able to do, I would have thought that there's some type of vascular stenosis that both led ultimately to stroke and was leading to either TIA or transient, TIA by the mechanism of artery to artery embolism or transient occlusion that was causing the losses of consciousness. But we know the vessels are clean. So if this was cardioembolism, and what were those other events? Were they also cardioembolism, but why do they all keep going to the posterior circulation, whether it's PFO or AFib or whatever? So that is what makes me a little bit uncertain, but I do think this syndrome, I can't think of a time I've seen it and it wasn't from stroke. But we have 2 minutes to find out. So Antonio, the three of us, well, Sammy and I think it's a stroke. Shema is thinking it might be a stroke, but wants to stay open, which is always a wise move. And let's see where things landed. Okay,
so the final diagnostic test was an electroencephalogram. No, I'm kidding. It was an MRI.
You got us. I thought, wait a second.
I'm actually going to show you the images. I know everyone was waiting for the.
Yeah, are you a co-host?
Sorry, I'm not sharing my screen. Sorry.
Let's make you a co-host here.
Okay.
Oh, you are a co-host. Yeah, great.
Sorry, let me
check.
Okay. No, wait.
Neurology still works. I remember when I was a student on my radiology rotation, the echocardiographer said, by the time you're all in practice, you won't need the stethoscope anymore because the echo is so good. And I remember how horrified the students were. And so when people say to me, aren't you neurologists going to go extinct? All you do is localize. Can't you just get an MRI? First, you can't always just get an MRI. And second, you have to know what to get an MRI of and where to look, right? And here, Shema, based on the physical exam findings, was able to localize this at centimeter precision. How cool is that? That's how cool neurology is. To the right side, to the right level of the brainstem, and to the right aspect of the brainstem. Right as in right and as in correct. So if you go back, Antonio, to the first thing you showed us, oops, maybe one before that, this one. So this is, do you want to tell us, or I can say either way, it's fine with me.
Yeah, so if you want, I can just finish off the case.
Oh, sure.
To discuss. So yeah, we did, of course, an MRI, and it showed, this is the T2 images, and you can see, of course, a lesion on the inferior right medulla.
You want to just point, Antonio, just for people who are less familiar with brainstem anatomy?
I can, yes, here.
Yes, perfect.
Yes, and here, and then here, this is a flare image, so you can see the hyperintense lesion as well, and this is the diffusion wave imaging, and here you can see also hyperintense, and this is the ADC, where you see hypointense, which I hope I'm not saying this wrong, but basically confirms that this is from ischemia and not other pattern of restricted diffusion or something. I know this is important in press, for instance, but I leave it for Aaron to discuss. So yeah, basically you were all right, and Shema pointed it out immediately, and I could see also Aaron's face lighting up with the physical exam. This is a case of Wallenberg syndrome due to acute ischemic stroke, and sorry. Yeah, I stopped. I can share the images still. Sorry.
That's okay. And Antonio, what did you and your team make of the? Yeah. What did you think the cause of the stroke was, and what were those loss of consciousness episodes? Maybe you did also do an EEG.
No, actually, we just looked it up on the internet. Of course, we started to, because our first impression was. The description of the patient really looked like syncope. And of course, we learn in medical school sometimes stroke could be a cause of syncope, but we almost instantly say that's impossible. What you could have, it's like basilar insufficiency causing ischemia to the reticular activating system, like you mentioned, Aaron. But actually, in this case, we found some. Actually, we only found one case report of syncope in Wallenberg syndrome, and apparently the mechanism is from ischemia to the nucleus tractus solitari, or from the sympathetic fibers that cause the Horner syndrome, and that causes autonomic dysfunction and failure that is really compatible with the presentation of orthostatic hypotension that the patient really gave a good history for. So this is a really interesting case. And as to the cause, Sammy was mentioning PFO, and actually I didn't give you, just not to cause much confusion, but on the echocardiogram, it seemed to be positive for a PFO. There seemed to be some bubbles passing through one side to the other, but only after 6 beats or 3 beats, I think. And so we did a transesophageal echocardiogram, but the patient was deeply sedated, or a bit more sedated than he could be, so he didn't cooperated with the Valsalva maneuver. And so we did another cool thing, which is
Cranial Doppler.
Cranial Doppler that seemed to be positive for shunt, a right to left shunt. And we asked for an opinion of a colleague that specializes in PFO, and she actually thought that with being a 50-something man, obese, and with hypertension, that it probably was paroxystic AFib, and he started on a anticoagulant. I forgot to give you the Holter 24 Holter monitoring that was negative. But we thought that it was unclear the cause between PFO or more likely a paroxysmal AFib, because his rope score was a bit not too much compatible with PFO being the cause. So yeah, basically it's Wallenberg syndrome with autonomic failure causing orthostatic hypotension and syncope.
Wow. So the first episode of loss of consciousness, did he notice since that first episode, the left-sided sensory loss and the ptosis and all that stuff was there from the first one, or?
The ptosis, he actually, because some of the things were not clear to him. The right eye ptosis was not clear to him. The loss of temperature was not clear to him. Only when he had a shower, it was clear to, or really, really clear to him. And what was his main complaint after the loss of consciousness was his unsteadiness that was due to his ataxia. And also he mentioned something that was unclear in the emergency department. He just mentioned, I feel a bit dizzy. It was not clear if it was dizziness, vertigo, but it was really clear that he had impressive nystagmus, multidirectional nystagmus.
I see. Right. Yeah. Patient might not notice their own Horner's or sensory loss, but probably if we want to wrap this up in a package. So you taught me, I've never heard of lateral medullary syndrome causing autonomic dysfunction to the point that the patient has loss of consciousness. Though one of my residents, and I wrote a paper many years ago looking at cardiovascular complications of multiple sclerosis, and she found all these case reports of lesions in very atypical places in the brainstem causing arrhythmias and Ondine's curse, hypoventilation, and all this stuff. That's Tammy Kaplan is the first author on that paper if people are interested. And my mentor, Marty Samuels, did a lot of foundational work in sort of the medicine of neurology and neurology of medicine, and talks about the cardunculus, which is the autonomic homunculus in the insula. I always forget, but one side is sympathetic, left and right is parasympathetic, or vice versa. And if there's a seizure in one of them, you can get the type of arrhythmia from activity there. And if there's an ablative lesion like a stroke, you can get the opposite. But he would love this case. I'll see if I can ask his opinion about a lateral medullary syndrome from the effects on the vagal nuclei, which are back there causing loss of consciousness. That's fascinating. But presumably the first episode then was the stroke and the symptoms that we identified as Wallenberg syndrome were just not apparent until he saw a doctor. Not that he was having stuttering episodes that then became the Wallenberg syndrome. Is that right, Antonio?
Yeah. So just the other case report that we found actually was of a sick sinus syndrome from Wallenberg syndrome. So basically the same as autonomic dysfunction causing bradyarrhythmias or bradycardia. Here, basically, the patient had a sudden loss of consciousness, and then he immediately went to the emergency room. So,
I see.
Not much time elapsed for him to understand and to characterize further his neurological symptoms. Just that he felt unsteady and that he could not stand up. He could not be able to stand up.
Right. Very interesting. Well, it makes sense. People have heard me talk about the brainstem before. If you can't remember where all the cranial nerve nuclei are, quick first passes, midbrain 1, 2, 3, 4, pons 5, 6, 7, 8, medulla 9, 10, 11, 12. There are some exceptions. 5 is at all 3 levels. 8 straddles the pontomedullary junction. 1 doesn't go to the brainstem. 11 doesn't go to the brainstem. But 9, 10, 11, 12 are back there in the medulla, and vagus, which obviously supplies the parasympathetic input to the thoracic organs and the abdominal organs up to the last third of the gut and the genitourinary syndrome system. That nucleus is back there in the lateral medulla, so it's certainly possible that if it's affected, the patient could have intermittent bradycardia and syncope. It might be interesting to do prolonged cardiac monitoring in this patient and see if you can capture what the arrhythmia is, and then you could probably write a case report about it. The delayed bubbles are interesting if there's no PFO. You can get delayed bubbles also if there's a pulmonary shunt. And pulmonary AVM, you can see that in Osler-Weber-Rondeau syndrome. I saw a case report about that recently. So the delayed bubbles, sometimes it's not the PFO, the delay is because they're going through the pulmonary system. And of course, none of this any apparent relation to the liver transplant or immunosuppressives, which were, when we all heard about them, we all tried to tie everything together, but we're not part of this case. Well, thank you so much, Antonio, for bringing what ultimately was a classic case, but with a very atypical presentation and a very atypical context. And thanks to Shema and Sammy for their brilliant discussions of this case and perfect localization and diagnosis, and for teaching us the correct pronunciation of Wallenberg syndrome. So we've now learned from one of our French colleagues that it's not Guillain-Barré, but it's Guillain-Barré. And now we know it's not Wallenberg, but Wallenberg syndrome, thanks to Shema and Sammy. I know we've run over, but that's our tradition in Neurology Morning Report because it's just too much fun to talk about all this stuff. And Maria, do you want to take us home with some teaching points?
Oh yeah, this was a great case. I'll do it very briefly. We started with loss of consciousness, and with that, you can always try to first branch neuro versus non-neuro, and we heard some very great mnemonics. The mismnemonic, and you can think of metabolic, infectious, structural, and toxin causes. You can also think about the 5 S's: sugar, syncope, seizure, stroke, and sleep. I really we tend to think about time and localization, and with time, I never thought about it this way, but with loss of consciousness, also consider acuteness, but also consider, the pattern of the time. So if it's progressive or transient or episodic, and all of those will give you great hints, just like we did here. And then we started hearing other things that we weren't expecting, like the vertigo and imbalance. And when you have 2 different symptoms and localizations, as we did here with loss of consciousness and cerebellum findings, always try to Venn diagram first to see if you can sort of find something that's there. And we started thinking about posterior circulation TIAs and strokes. And then ultimately, in this case, it works. Sometimes you have to pick the CC with the most gravitational pull, but it's always a nice exercise to try to Venn diagram both of them. Then we heard the most interesting physical exam. We have tons of localizing pearls. We started with the multidirectional nystagmus, which makes us think about central causes and not peripheral causes. Then we heard about cross signs, which localizes to brainstem, and then always thinking, is it right or left? It's contralateral to the body and ipsilateral to the face, and that's going to give you the right or left localizing part. And then with sensory, we tend to think about lateral brainstem, and with motor signs, we tend to think about medial. Well, we don't tend to think, they're localized to the medial brainstem. And with cranial nerves divisible by 12 are medially located, and the other ones non-divisible by 12 are, I don't know if I'm saying that correctly, but I think you get it, like 6, 2, 3, 4, those are medially. 12, and then the other ones are lateral.
3, 4, 6, 12 medial, 3, 4 midbrain, 6 pons, 12 medulla. I call it the motor elevator down the middle. 3 oculomotor, 4 trochlear, 6 abducens, 12 tongue, and then bronchial motor, which are 5 motor for mastication, 7, and then 9, 10 are slightly more lateral, the bronchial motor, and most lateral are sensory, special sensory. You got it. Perfect. Just highlighting and taking 2 out, which
it's
is
always super interesting to see how people do math. Now you can see that I can't divide by, like, so no. And then we had ptosis, which we think about cranial nerve 3 or sympathetic branch, and then try to use the pupil to figure out which one is it. In this case, it was meiosis, so we tend to think, you think about Horner syndrome, and if it's mydriasis, we think of cranial nerve 3. So we have all of this localizing features, which ended up being Wallenberg syndrome from pica stroke. From pica territory. We didn't get to stroke really that fast. But with Wallenberg syndrome, I'm gonna say it like the correct way. There's tons of different findings, and it all has like an explanation. So you have Horner syndrome due to affection of sympathetic fibers, ataxia and dysmetria, due to affection of inferior cerebellar peduncle, loss of pain and temperature contralateral to the body due to spinal thalamic tract lesion, and loss of pain and temperature ipsilateral to face, secondary to spinal trigeminal nerve lesion. Cranial nerve 9 and 10 affected. So that's dysphagia, Horner's, loss of gag reflex, which tends to be like the most characteristic sign, which we didn't have here. So I thought that was interesting. And then we also have like the vestibular nuclei, which in this case, which causes vertigo and nystagmus. And we also have vagal nuclei, which in this case has this very interesting explanation of how that can cause autonomic dysfunction and explain like the transient loss of consciousness we started with. So full circle to where we started. And then lots of interesting findings, but at the end it was due to an ischemic event. So that was the amazing case of today. Thank you all so much for participating.
amazing teaching points, Maria, summarizing some both high level and detailed, nuanced gourmet neurology amidst. And then you put a link at the end. Just curious what the.
Yeah, thank you for reminding me. This is a link to one of Gabby's infographics on Wallenberg syndrome. So check it out.
Fantastic. And look at us all pronouncing this appropriately now, so that when we go on rounds, people will say, what syndrome? Oh, you mean Wallenberg? And Shema and Samuel have to hold their ears at how we pronounce it. Very good. Well, so nice to see everyone again after being out for a little bit, and hope you enjoy the rest of your day, evening. And if you have a case you'd like to present next Tuesday, we would love to have it. And if you saw how much fun we all had today and would like to participate, we would love that too. Thanks, everyone. Have a great day.